Mr. Doggett, I yield to you.
Thank you very much. Thanks to each of our witnesses. Dr. Dongili, I've been out to a long-term care hospital, I think similar to the one that you operate with Dr. Prettyman, who's here with you today, and seeing firsthand the big challenges you have to provide quality care to people that really need extended care. And I was alarmed by your written testimony, I didn't get to hear all of the oral, that the discharge rates to long-term hospitals are about 40% lower for those enrollees that have Medicare Advantage versus those in traditional Medicare. When someone is not approved by their Medicare Advantage plan to come to a long-term care hospital of the type you direct, what happens to them? What care do they get?
One of two things can happen. They can continue to receive services in the short-term acute care hospital, which often does not provide the comprehensive services that a long-term care hospital provides, with dedicated respiratory staff, interdisciplinary teams, and an integrated care plan. Or they can stay in the hospital for a period of time and then decrease to a facility that is less intense, that might not have those resources in place to meet their needs, and languish there, or perhaps transfer back to the short-term acute care hospital because of the lack of that care.
Well, I think Medicare Advantage is a real problem for taxpayers since they get overpaid, as has been pointed out by the independent MedPAC, and it's a problem in terms of quality of care in this situation and others. Perhaps they've been able to maintain this position where they don't save taxpayers any money, they cost us billions of dollars in providing lesser care by the fact that they invested in this Congress $330 million in lobbying expenses between 2020 and 2024. Dr. Madison, we have visited previously about the challenges that home health care faces in Texas. I know you're aware that if Texas legislature that is already pretty stingy with its Medicaid program has to cut it even more because more responsibility is shifted to the state, that, just like the Medicare issue, will impact what you're able to do with home health care. And I suppose overall my feeling is, Mr. Smith referenced the legislation last year. It's entirely unclear to me, especially on the long-term care hospitals, why it is we're having a hearing in March when I thought we were going to get legislation up for consideration last fall. But I suppose that's the troubling position we're in of inattention to these issues. Certainly, Mr. Carlson, I'm pleased that you focused on the nursing home standards. You have emphasized the impact, and I want to explore that with you a little more. It's been referred to as a political decision, and I suppose that's right. There was a political decision that it was worthwhile, as predicted and estimated with these standards, that we could save about 13,000 lives a year by properly staffing our skilled nursing homes. The conditions have become so bleak that the average nursing home is today turning over more than half of their staff every year. We don't have a true workforce shortage. We have a shortage, I believe, of decent working conditions, wages, and fair treatment of care workers. Nursing homes have the funds to create better working conditions. Again, referring to MedPAC, their 2023 report found that skilled nursing homes have profits that exceeded 10% for 22 consecutive years and were as high as 17%. And that's with them finding that 1 out of 5 facilities have more than 100% of their costs fully met by Medicaid. I just ask you whether there are sufficient workers out there to meet these minimum staffing standards, despite the claims of the industry to the contrary.
Thank you. The first, of course, is the context of this is really important and necessary to make sure that residents get the care that they deserve. As I mentioned in the testimony, there have been numerous accommodations written in the regulation to make sure that this is practicable. The standard selected is not as high as certainly some people advocated for. It's a standard that's already met by 60%. The overall standard is a standard that's already met by 60% of the facilities in the country. There's a significant phase-in period that allows facilities for rural facilities until 2027 and 2029 to fully meet these standards. And also, as I think you rightly point out, this is a retention issue to a significant extent. There's a vicious cycle in nursing facilities sometime where you're short-staffed, and then terrible working conditions, and then people leave and you're short-staffed. The idea behind this regulation is to staff appropriately so it's a good environment for residents and for staff members. And then finally, I'll note that as I mentioned, there is a hardship exemption. If facilities try and make their very best effort, there's a demonstrated labor shortage in that region, and the facility shows that they have offered prevailing wages, they are exempted from penalties for this provision. So in these multiple ways, the standards recognize reality and balance the need to provide good care with the other factors that have to be dealt with and understood.
Thanks to each of you.